Hello, my name is Sean Kim. I'm a PGI1 from Mary Washington Healthcare. This is our case report on an interesting patient we encountered during the clinic day. Patient is a 30-year-old female who presented with left hand pain and right third and fourth finger pain. Patient had no history of diabetes, smoking, eczema, or lymphedema. However, patient reported a recurrent episode of cellulitis on her left hand this past 9 years. Of note, her past cellulitis was treated with Keflex. She had no triggering event that could have led into the first episode of cellulitis. The only trigger she reported was that she always had dry skin due to dishwashing and frequent exposure of her hands to water. Of note, the patient only recently started to use gloves when dishwashing. Regarding most recent symptoms, patient reported that her current symptoms started a week ago with left fourth finger pain similar to the previous cellulitis episode. Then new symptoms of pain and warmth in her right third and fourth finger started about 3 days ago. She had no obvious triggers for this episode, such as trauma or outdoor activity. Our physical exam revealed erythema of the patient's right third and fourth finger lateral nail fold. The nail folds were swollen and tender to palpation. The nail folds borderline was vanishing as the finger was swollen. The third finger lateral nail fold appeared somewhat fluctuant, and the patient reported she saw pus draining out of the finger. Examination also revealed that her right third and fourth finger pulp had tenderness to palpation. Unlike the right hand, the left fourth finger only showed dry skin and minor tenderness around the distal tips of the finger. During range of motion and strength testing, the patient demonstrated a normal range of motion of her fingers joints bilaterally, as well as normal strength. We diagnosed patient with right finger pyronychia and felon. We also diagnosed her with chronic left finger pyronychia. We treated her with Bactrim topical chlorhexidine and advised her to do warm compress and had her use mupirocin 2% cream for her right fingers. We also treated her left fingers with betamethasone valerate. The patient was seen for a follow-up visit after 7 days. At that time, her affected fingers were still slightly swollen, but no other symptoms were present. We picked this case because recurrent cellulitis and infections like pyronychia are commonly seen in primary care offices. Family medicine physicians need to be aware of risk factors in order to treat these recurring infections properly. Most well-known risk factors of recurrent episodes of cellulitis and pyronychia include venous insufficiency, diabetes, chronic edema, exposure to irritant, and trauma. However, family physicians should also be aware that cellulitis and pyronychia can be caused by lesser-known risk factors, which include history of cellulitis, smoking, homelessness, previous tonsillectomy, and dermatitis. This case illustrates that recurrent hand cellulitis and pyronychia can happen due to lesser-known risk factors like insufficient skin care and a prior history of infection even after successful treatment. When it comes specifically to hand cellulitis and other infections, more exploration is needed to identify patients at risk and to employ strategies to mitigate that risk. Although there is no standard criterion for prevention and treatment of recurrent hand cellulitis, our case report shows the need to identify various risk factors for better outcomes and to reduce recurrence of infection. In our patient in particular, more workup is needed to determine if there are any other possible connections between predisposing conditions to her recurrence of disease. Thank you.